Hello and welcome to the webinar today. This is, as you know, this is my most favorite day of the month is when I get to talk to everyone. We have a lot of questions today, and so it's going to be some pretty interesting and diverse topics that we're going to be talking about. First of all, I would just like to say I hope that you have stayed safe over these last this last week of December with all this weather that's going on. I know it's spoiled a lot of people's holiday plans, including my own. There was some alterations that had to be made. Fortunately, my family lives close by, so I didn't have to fly, so that was nice. And the family that did fly in had flown out before the bad weather had come, so that was good. But I always like listen. Well, I don't enjoy listening, but I always try to listen to the news when people are talking about what the effects were, like not being able with all these airline cancellations. And I always think, what would people be doing if they had some kind of challenge to their health and they all of a sudden they couldn't get a flight out for 4 days and there's no hotel room, so there's no place to sleep with specialized bedding. There's no place to maybe, the toilets are accessible, but we all know how accessible public toilets are. Some are and some aren't very. And there was one lady who said, well, I packed my medicine for the trip, but for while I'm going to be gone, I have that in my suitcase. So she only had a day's worth of medicine with her. And they always say to keep all your medicine on your person. And that's an important thing to remember. And then the other thing was somebody said that they only had enough baby formula for the trip. And then they, the rest was packed away. And I thought, oh yeah, it's all those things that, you can't carry everything on board, but what on earth are you going to do? And so just as a reminder to people, if you do have health issues, you can call the airport security and ask them for advice or, a place to go, a place to stay. Sometimes they can make arrangements for you to stay someplace where your healthcare needs are taken care of, even if that is a shelter. But just so you know that there are options available in case some horrible thing like this happens again. Now they say it's a once in a lifetime, but I have the feeling that this is not the last we're going to see of these big storms. Anyway, just to let you know, Nurse Linda had to alter her plans because I've become very modern. I was invited to my very first gender reveal party. How exciting. And I thought, oh gosh, this is so different because, I read about it online and, you see them, you hear about them, but I had never been to one. So I was kind of all excited, very disappointed because it had to be canceled, not only because of the weather, but because the mama-to-be got the COVID. So, COVID, flu, colds, it's all out there. And our immune systems are not quite as strong as they used to be because we've been staying in, so we haven't had that exposure. We are exposed to germs, viruses, bacteria, really on a 24/7 basis. They're just flying around in the air, and most of the time our bodies respond and say, oh yeah, we know what this is, and it gets rid of it. If you have problems with your autonomic nervous system, it might not work as well. So, continue to be cautious because there's still a lot of this out there. If you have not gotten a vaccination and you're able to get a vaccination and you are of the persuasion to get one, please get them because that only helps with the symptoms so that if you get it, it won't be as bad and such unfortunate outcomes as so many people have had. Oh, by the way, in the gender reveal, we did it online, of course. That's the new way to do everything. And so we did it, and it's a baby girl. So we're very excited about that. Wouldn't have mattered which it was, but still it was kind of fun and exciting. So I had never been to one, so it was an abbreviated party, but still it was kind of fun to do all of that. So today, just to give you some thoughts about what's going on, we'll just start into the questions, I think, because a lot of the stuff that I wrote about this month has come up in some form in the questions that people have written in. If you have any questions, feel free to put them in the chat or the question and answers, and we'll try to get to all of those as well. So the first question is somebody who started to use who is using digital stimulation, predictable and easier bowel movements. And yes, that's what it's for. One of the reasons why I wrote about digital stimulation, this is just a coincidence that the first question would be about this, but one of the reasons why I wrote about this is I was at a conference and talking to some healthcare professionals, and they were talking about digital stimulation, and they had some very odd impressions of what that was all about. So let's just talk about that a little bit. In that digital stimulation, I've yet to meet a patient or an individual who learns about a bowel program who says, oh, goody, I've been waiting to do this my whole life. It's always like, wait a minute, now what do you want? Now, what are you talking about here? Because, something that no one knows about out in the world. I don't know if that's a good or bad thing, but, it's not something that comes up in everyday conversation. It's not something you see on TV. That's where we get from the medical shows on TV is where most people get their medical education. And there's a lot of information on those medical shows, but they never talk about digital stimulation. And what it is, it's for people who have higher level injuries in the cervical, the neck, or the thoracic, where your ribs are on the spine bones. Those are upper level injuries, and lower level injuries are in the lumbar and the sway of the back, and then down at the sacrum at the tail. So if you have a higher level injury in the cervical or thoracic region, you usually have a hyperactive bowel. It has tone. Individuals with these kind of injuries often have tone in their body where they get spasms. Tone is the new word for spasms. So the bowel is also what's outside the body. What you see outside is usually inside. So the bowel can also be slow from the spinal cord injury. So it's slower to move the stool along, but it's also spasmy. And so there's two sphincters. One is at the opening to the rectum, and that you can see, that's your rectal opening. That's the outer sphincter. And that is under your mental control. Now, if you have a spinal cord injury, you might not be able to mentally control it, but that's the one that's controlled by your brain. The internal sphincter is the one that's controlled by the autonomic nervous system. There it is again. So it tends to stay tightly closed. So you put together the combination of the slow moving bowel, which makes it difficult to get that stool to move along at a nice pace to get going and moving through the bowel. And then it meets resistance at this internal sphincter, which is up in the rectum, just the length of your finger. How about that? For pediatric patients, the parents who have to do digital stimulation, you might want to use just like the tip of your little finger because it's not that high in there. Look at how long your child's finger is, and that's about how long you want to insert your little pinky finger to do digital stimulation. For adults, it's about the size of your finger. Now, you might not feel the internal sphincter when you go in and gently massage it. With tone or spasticity, the rougher you are, the more it triggers more spasms and shaking. So people that want to get in and get out and do that digital stimulation, and they get in there and they start stimulating, and they may feel that internal sphincter, and you may feel it relax. You may not feel it, but you're going to be close enough to it with the length of the finger that you're going to be able to relax that inner sphincter. But people want to get in, they want to be aggressive, they're going to do it as fast as they can and get out, which is making the sphincter clamp even tighter. So it's making the bowel movement even harder to do. So you want to go in and be as gentle as you can. Stimulate for a good little while, maybe even 40 seconds, with a well lubricated finger, the whole finger, because that tissue in that rectum is soft tissue. It doesn't have skin on it, so it's not welcoming the outside world. So you want to have a well lubricated finger that's lubricated all along the glove of your finger. And then very, very gently. Now, it will take you a little bit longer to do the digital stim and to very gently relax that sphincter. But once it's relaxed, the stool can pass right through. So a lot of people complain about their bowel program takes so long. And when we talk about it, one of the main issues is that they go in and they're doing that digital stimulation aggressively to get that sphincter to relax, but aggressive stimulation is going to cause that sphincter to tighten. So that's one of the first things to say about digital stimulation. Now, as far as those who have the lower level injuries, they don't often do digital stimulation, but they will manually remove the stool from their bowel. And so that's the difference, that because they have an atonal rectum without tone, so that internal sphincter stays open. And then there's more issues with incontinence because the stool tends to roll right out. That's why you want to keep the bowel empty. So digital stimulation will help stimulate the bowel to move the stool down in the rectum, but it also relaxes that internal sphincter, and gentle, gentle, gentle is what you need to do. And so this person, if they're losing their natural function, if they're becoming dependent on DigStim, well, it's not that it's a dependency on DigStim like I can't go without it. It's a necessity if you have one of those higher level injuries to relax that digital sphincter. So it's not like he goes on to ask if it could be like an addiction kind of dependency. No, it's a necessary activity to get that sphincter relaxed. And so he's doing, he could have a natural BM, but it took 1.5 to 2 hours to succeed. Well, naturally, we don't want the bowel program to be that long. We aim for 20 minutes. Now, I know that, I know there are people out there that have no problem with their bowel program. 20 minutes, bing, bang, boom, they're done. Great, good, keep doing what you're doing. But there are other people that I know that work with their bowel program for hours and hours and hours a day. And most of the time it's because of the incorrect digital stimulation, but also it could be roughage in your diet, taking in enough fluid. He's got enough fluid in his diet. That would be the thing, is when you're doing the DigStim, it's a necessity for those higher level injuries to do that DigStim to relax that internal sphincter. So there's some information that's going in the chat box all about bowel programs. Oh, somebody had written in about gender reveal parties and pushing the vaccine hoax. Well, I'm sorry. You need to. I hope I don't feel I was clear enough about that. If you're able to get a vaccine, and if you feel like the vaccine will be helpful to you, then I encourage you to get a vaccine. But deciding that, if you know, that's entirely up to you. So I apologize if I was not clear enough about that. It's at your discrimination, but talk it over with your healthcare professional, because everyone is different. And it may be that the vaccine is not appropriate for you, or you may have other ideas about the vaccine that you personally find that it's not appropriate to you. So don't feel like you have to make those decisions all all by yourself. You can get information from a variety of sources, and probably should, before you make that final decision. And if you don't want to get it, then that is at your discretion. So there's a product about D-mannose. Is D-mannose a good product to reduce urinary tract infections? A lot of people use it. Some people have success with it. Some people don't. Again, this is a question in the chat box, and this is one of those questions that everything that people do is so individual to their own bodies. So sometimes some of these products can increase bacterial infections in your body, and sometimes they actually reduce them. Talk to your healthcare professional and find out what is right for you. A lot of people don't have any problems with urinary tract infections at all, and some people seem to have a lot of issues with them. And the way it seems to drop out is how well your autonomic nervous system is working and recognizing that bacteria and eliminating it. So the autonomic system may not recognize the bacteria and tell the brain we need an internal antibiotic. Your body makes its own antibodies as well. And we need this, and we can get rid of this invader right away. Sometimes it's slow in doing so, which gives the bacteria much, much more time to keep multiplying and making it more difficult to eliminate. And then sometimes there's just no response at all. So any of those things can happen. So some people use different products and they do different things, and they've had a lot of urinary tract infections, and then they stumble across a product that works for them. The next guy comes along and he stumbles across the product and it doesn't work for them at all, but something else will. So just keep up with trying different things. Talk to your healthcare professional to find out what would be the best for you. Sometimes a lot of these products have a lot of sugar in them, and so that helps feed the bacteria. So you want to be aware of that. There's also a brochure that's come up about bladder infections, which it has a lot of information about different things that you can try and different things that you can do. There's another question. Oh, this is a great question, since this is just going so smoothly today, because here's a question about bladder issue. And it looks like tons of dust particles in my urine, which I can see at certain angles when I look to the toilet. And I feel like so many times I never fully empty my bladder. That when you see the tons of dust particles, these little white, like crystal-like things in your urine, that's called sediment. And it comes from a variety of different things. It could just be the way your urine is, could be normal for you. It could be a sign of infection. It could be a sign of losing bone density. So it can mean a variety of different things. Some people just have a lot of sediment in their urine, and that's just the way it is for them. It's amazing that you can see them when you look in the toilet, because most people can't see sediment. Everybody has a little bit of sediment in their urine. Some people have more than others. But usually you can't see it in the toilet because most toilets are white and the sediment's white. By the time the urine's in the toilet, it's diluted in the toilet bowl water. So it makes it a lot more difficult. People usually see it if they're catheterizing and their urine goes into a bag or some kind of drainage bowl or something that they're emptying their urine into. So that's usually when they see it. But if you're concerned about that, I would recommend that you talk to your healthcare professional. You may need to have a urinalysis to see what that is. If you don't have any other symptoms of a urinary tract infection, it could be that you don't have a urinary tract infection, or you could have the beginning. I know there are some patients who only get sediment right when the urinary tract infection is starting. So that gives them time to call their doctor and alert them. You know, they know their bodies that well. So it's time to get a urinalysis and talk it over with your doctor to see what the cause of all the sediment is. So that would be an important thing. But as I say, it could be from a lot of things. So there's a question that somebody wrote in about long-term COVID. And do you see a lot of the effects in individuals who have spinal cord injury? And if they had COVID and they're having some effects. So there are people who have had long-term COVID with spinal cord injury who do have some of the neurological effects. It's make them feel weaker, or they don't have the strength that they used to have in the parts of their body where they used to have some strength. There's some effects in brain where you kind of get that brain fog. There's some skin issues. It started out way in the beginning of COVID with people getting something called the COVID toes. And that was like a lack of oxygen way down to the toes, where that's the furthest part from your body part from your heart. And so they were getting this kind of anoxia in their toes from the COVID. So those kind of things are the same. The difference being between those people who have long COVID and those people who have spinal cord injury and long COVID is that they usually see an exaggeration of their neurological symptoms. Now, when COVID first came out, we thought, because of the autonomic effects of the autonomic nervous system, people that get COVID are going to have a real struggle. They're going to be very sick. It's like 0.1% difference in the symptoms of people who had spinal cord injury who had COVID versus people who do not have spinal cord injury. So the effects are very, very similar. Now, because of the difficulty in the autonomic nervous system in responding to COVID, people thought this is going to be very grim for the community. But what happened was because people with spinal cord injury with autonomic effects, not everybody has autonomic effects with spinal cord injury, but those people who had an autonomic effects fared just as well as people who did not have spinal cord injury because they weren't able to build this huge immune response and get into this crisis mode. And so they actually did as well as people who didn't. So that was a big surprise to everybody. You know, you think the body works this way, and then lo and behold, you find out, well, it didn't, it worked differently. So that's a good idea. The next question in the chat box is, please recommend resources to learn exercises to strengthen shoulders. Well, yes, I happen to be up on this because I have rotator cuff injury just from years of abuse. So exercises that you can do include, you know, doing some arm strengthening. I can put my arm all the way up now, I'm proud to say. So I've been doing therapy for my shoulder rather than having a rotator cuff repair surgery. There are some things that physical therapy is now showing to do just as well or even have better outcomes than surgery. One is rotator cuff. Most people get rotator cuff with spinal cord injury that use wheelchairs because they put their arm way back to get a good spin on that wheel if they're using a manual chair. And then that pushes them along at a faster speed. And they like to, you know, people like to move fast. If you're in a chair or not, people like to move fast. And so that's usually where it comes, is from that stretch way back in your arm. So you should always just put your arm down straight from your body and start at that high point of your wheel and then push forward. Now you'll take a lot smaller, it'll take a number more of pushes to get going and get going faster, but you can go fast even doing that way, and that helps avoid it. Another one of the issues is using your arms to move your body. So that's another issue, is that pulling your body weight around can be detrimental. So you can talk to somebody about early prevention and using adaptive equipment as you get older to help that. Peter writes in, and he's working on a rotator cuff. All right, partner. The TheraBand exercises, the shoulder pinches, all of that. The TheraBand, you know, that's that big rubber band that you use in therapy, and pulling your arm back and forth this way, and then pulling it this way. Like if you put the resistance, so you're pulling this way, put the resistance, so you're pulling that way, pinching your shoulders together. You always want to check before you start doing this to make sure that that is what your injury is. So check with your healthcare provider to make sure that that's what your problem is. But you can strengthen your arms doing those exercises. If you have a washcloth, running it straight up the wall and straight down maximum, keeping those arms and those muscle strength, and then also running it at a diagonal over here. That's another one to do. So all of those things are important in keeping the arm strength. Doing any kind of, if you don't have a rotator cuff injury, but you want to avoid them, doing some strengthening exercises for your arms with some weights, and moving all your arms in all different directions, starting out with a real light weight and then eventually moving up over time. You know, people like, oh, I did a 1 pound weight today, I can do a 2 pound weight tomorrow. No, do it over time. We're not training for the Olympics here. We're training for life. So do it slowly so that you don't move so fast that you've injured yourself. Now people will say, oh, I'm exercising because I'm moving my body all day, but that takes certain muscles. And then there are other muscles that are not used as much when you're doing that in your arms and your shoulders. So be sure and, you know, do your exercises as well. Here's somebody who's 51 years old, and they've started since June to have a terrible cramp in their right foot that went through the right calf and up their right legs. And in a few months, they started, it just progressed that way. Now they're having hot flashes with paralysis in my lower extremity, moving up to my shoulder and upper extremities. Because being scared of pressure rises, I start stroke-like symptoms such as slurred speech and rapid heartbeat until I'm completely temporarily paralyzed from the neck down. Could this be part of menopause? No, this is a neurological problem. Now, menopause has many of those same individual symptoms, but not with the stroke-like symptoms. So it sounds like you could either, since it's starting from a muscle cramp, it could be spasticity or that increased tone, or it could be that you're having blood clots in your legs. And there's a wallet card that the Reeve Foundation has for that. And that's there. We have little wallet cards. They fit just in your pocket, so you can read those. You can take them to a healthcare professional. If you have to go to the emergency room, not everybody has seen people with spinal cord injury, even if they learn about it in school, but spinal cord injury is really a very rare phenomenon. So it's not very rampant in society. So you can go to an emergency room with very experienced professionals who've never had a patient who's had a spinal cord injury. It's totally possible. So just knowing that, but with stroke-like symptoms, I would call and I would check with my healthcare professional. They've had a CAT scan, or they've had ultrasounds, EKG, everything's normal. And so they're talking about alternative treatments. So just be sure and follow up. Sounds like you've had all the testing. Be sure and see a neurologist if you haven't seen a neurologist yet, because you could be having little TIAs. You could be having blood clots that maybe are not there by the time you go and have the testing done. Maybe the blood clots already moved. So keep following up with that, because, follow up as the doctor has ordered for you to follow up, but also see a neurologist who, if you haven't seen a neurologist yet, be sure and see a neurologist to check to make sure everything is as it should be. There's a question about cellulitis and sepsis. We were talking about sepsis before. So what is the difference between cellulitis and sepsis? Well, cellulitis is an infection of the cells. So it can be inside the body, it can be outside the body, it can be a spot on your skin, it can engulf a whole leg, it can be a big spot. But cellulitis is an infection in the cells. Sepsis is an infection that is starting to travel through your bloodstream. So it's able to go throughout your body. Septic shock is when it starts, sepsis, the infection from sepsis starts in affecting your internal organs. When you get to septic shock, that's a real problem. If you need the emergency treatment. If you have sepsis, you need urgent and sometimes emergency treatment with sepsis as well. It's not something to fool around with. You can have cellulitis and have an infection somewhere in your body, have it treated, take the antibiotics, and still sepsis can occur if that infection starts traveling throughout your body. So sometimes people have an infection, they don't get sepsis until after this treatment's over, because it hasn't eliminated all of the infection. So how do you know when you have it? Well, you'll have fever. Sometimes people have cognitive changes. You might not be exchanging oxygen well. You might get blue tip fingers or around the mouth. But if you look at that sepsis card and keep it with you. So if you think you have sepsis, one of the things that if you go to the emergency room, sepsis is a pretty rare thing to have happen. So they'll start testing, looking for an infection. They start working up the differential diagnosis. That's, you start with the simplest thing and then you go to more complicated. Take the sepsis wallet card with you if you think you have sepsis, and say to people, hand them the wallet card and say, I think I have sepsis. When the nurse comes in, say, I think I might have sepsis because I'm having this, this, and this. When the doctor comes in, I think I might have sepsis. If another nurse walks in, say, I think I might have sepsis. You want to keep it in the forefront of their brain. So instead of starting out here with, let's try to decide what's wrong, you want them to start, let's shoot right for sepsis and see what's going on. They can give you a blood test, then they'll know, and then they can start the treatment. You don't always have time to mess around with sepsis. It can move pretty fast. So keep that wallet card with you. There are some other wallet cards too, one of which is for autonomic dysreflexia. Be sure and get that wallet card. There are 3 wallet cards that the Reeve Foundation provides They're for emergency things that happen to people who have spinal cord injury. And actually, some people who have head injury will have these things as well. So it's a good thing to keep this information. You can hand it to a healthcare provider. You can give it to your caretaker so they can be aware of symptoms. Has all the symptoms. It has information to the healthcare provider. That's very non-threatening. Not like, we're going to tell you how to treat this patient that we don't know. You're in charge. You're the doctor. But here's the information for healthcare provider. And here is the research articles that justify that these are the treatments that should be done. So it's very non-threatening. You can give it. I was reading this brochure. Do you think this could be what it is? And then hopefully you can get some early treatment. Another wallet card is for autonomic dysreflexia, where your blood pressure shoots up. The number one symptom of AD is a pounding headache, but there are many other symptoms too. Fuzzy vision, goosebumps, sweating. There are just all kinds of symptoms. Stuffy nose. You can have AD and have not the classic pounding headache that everybody learns about in rehab, but you can have these other symptoms as well. And it's just as threatening to your health to have these AD episodes where your blood pressure shoots up. So you want to have a blood pressure monitor that you can check your blood pressure at home to see if you're rising 20 degrees of millimeters of mercury in adults, 15 in children. If you have this rise in blood pressure, some people don't have any symptoms at all. They call it silent AD, silent autonomic dysreflexia, just while they're doing different things, especially like during a bowel program, during catheterization. So it's important to take your blood pressure. You don't have to have the blood pressure on 24/7, but it's important to take your blood pressure while you're doing different activities, even sleeping. If you wake up to catheterize, every once in a while, check your blood pressure to see if waking up stimulates an AD episode. Some people have AD at night, they don't know it. So be sure and get that autonomic dysreflexia card, the sepsis card, and the other one is for DVT. So they're all very, very helpful. Finding a doctor familiar with paralysis, it can be hard to do. They're not physicians in every area that specialize in spinal cord injury or paralysis from stroke. So especially if you live in more rural areas, there might not be a specialist. A physiatrist is a rehabilitation doctor who specializes in paralysis. There are also physiatrists who specialize in spinal cord injury in particular. That's also very helpful. And if you can't find a physiatrist, they will have the education about it. But if you can't find a physiatrist in your town, you can check around for a neurologist, call the office. Does this person have experience in spinal cord injury? Or if you have hemiplegia, does this person have experience in this? So finding a doctor is helpful. If you can't find anybody immediately, you can call an academic medical center where they have a physiatry program. Not every state has one, but just about every state does. That's where they educate physiatrists. So you can call them, ask for their alumni department, say, I'm looking for a physician in XYZ town where I live who has experience in physiatry, and they can tell you if there's a graduate of their program that lives in your area. You can call the American Spinal Association, and you can ask if there's somebody who belongs to that organization that's credentialed. You can call the State Board of Medicine and ask for somebody. Every state has a board of medicine and nursing and dentistry and all the healthcare professions, and ask if there's somebody who's a certified practitioner in physiatry. So that's another one. So those are just some ideas. You can search for on Google physiatrist near me and see what comes up. Sometimes that will come. If you get a couple of names, you can visit a couple of them. You can always get second opinions and find somebody whose personality kind of meshes with your own, if that's important to you, or if you just want them there for the nuts and bolts, then, find out. I think in physiatry, you need somebody who really listens to what you have to say, and that's what they are educated to do. So that's an important thing. So those are just some ideas. If you know somebody else who has paralysis, ask them who they see. They might know a doctor that's helpful as well. Here's a question for a quadriplegic who has to drink out of a straw. What can I do about flatulence? The gas we pass. Everybody does it. Fortunately, people who have, I shouldn't say fortunately, but people who have sensation in the rectal area and control over that outer rectal sphincter can squelch their flatulence. It's not always a good thing to do because it backs up into the bowel, stretching the bowel. But, we all know about the silent but deadlies because people who have control of that external sphincter have that ability. People who don't have control over that external sphincter, the gas just passes, and sometimes it can be loud. Sometimes drinking through a straw, yes, adds more air into the bowel. It's very little. It may seem like more, but it's more the problem with the external sphincter just letting loose whenever it needs to do that. So you can check with your healthcare professional and see if you can take one of the products like Beano or some of those things that help stop that large collection of gas. But when we eat food and it breaks down in our bowel, gas is created. Now, some people with spinal cord injury shouldn't take products like Beano or things because they can slow the bowel, making it even more difficult to make that bowel program to work. So I say check with your healthcare professional. They might say, well, okay, if you're going out, for the evening and you want to take a Beano, it'll be okay, but don't do it on a daily basis. Or if you want to take a Beano at work, or something where you don't want to have that situation happen. You can try to eat foods that don't produce as much as gas. We always encourage people to eat a lot of fiber and roughage. That creates more gas, but it helps the bowel move. So you have to kind of find that balance. So there are some things that you can do to help with that gas, but the straw adds some air. Usually it comes out more as a belch. So, and that you can kind of maybe stifle a little bit. So, everybody's going to pass some gas. So you just have to find a solution and maybe a product, or there might be a medication, something that, will help settle that gas. Looking at reviewing your diet and eating less gassy foods can be a help too. So yes, there's a lot of new information coming out about SEI, and there's a question I know that's going to come up below, that when are the new electrical stimulators coming out that are going over the spine? They're supposed to come out in 2023. I haven't heard anything that they're not. So I'm keeping my fingers crossed. Now they should have come out a little bit earlier. There are some places that are already doing it, like the Cleveland FES Center already have some implantables. There's some different places around that are doing it. The Cleveland Center is going to be having their product. It's either out nationally or it's going out nationally shortly. We've done webinars with SpineX and Onward, and their products are supposed to be coming out within this next year, barring if we have another pandemic or, huge snowfall or whatever, depending on what's going on in the world, so they're on their way. And so, it will take some time and some training to get used to them. I know one of the things that we have highlighted is how quick people have adapted to these surface stimulators, which cuts out reduces, there's no surgery to them. It's a tape with stimulators that go on the skin over either up above in your neck and high area and high thoracic area, or down lower on the lower spine. And people are taking to them like a duck to water. So it does take time. So if you get one, or you get in a trial, or you're doing something with those, and it doesn't come that quickly, don't worry, it will happen. So those are kind of good things to know about. Now, here's somebody who says, and this is a wonderful, this is wonderful. This is such kind person. They're managing bowel care by spouse who was a wonderful kindergarten teacher, but not a nurse. So we've got all this bowel information for you. Yes, it takes time for the wonderful kindergarten teacher to get the knack of it. So it is difficult sometimes for people to regulate their bowel program. And there's a lot of things that go with it. How much fluid you take in, if you eat enough roughage, if you move, if you are paralyzed and you're never moving your legs, that is an issue for your bowels, because your bowels rely a lot on your abdominal muscles to work. So doing that range of motion exercises help. If you can get involved in standing, that helps. If you're doing your bowel program on a toilet or a commode, that helps. We don't want you sitting there for hours and hours because there's no foundation under your rectum. So, that can cause problems in your pelvic floor, and we don't want that to happen. But while you're eliminating the stool, it comes out much easier, much faster. Gravity is your friend. That is the one time gravity is all of our friends. So somebody wrote in, what does the stim do? I'm sorry, I missed it. So we discussed that, but I'm going to say it again because it's so important. Gentle stimulation with a well lubricated finger for about 40, maybe even 60 seconds, but very gently will reduce the tone and open the internal sphincter, which will let the stool in your rectum fall out and pass out of the body. So that's what you're trying to do, is relax that internal sphincter. It also helps stimulate the peristalsis in the bowel because there's an irritant, which a suppository or a mini enema will do as well. Will help bring that stool out of the body. It stimulates that peristalsis and it gets it all out, as opposed to just what's in the very last bit of the colon. It helps move the stool down. So those are all important things to do. So you have to put the stimulant, the suppository or the mini enema in. The product has to go against the bowel wall. The mini enema is like a teaspoon or a tablespoon. It's about 5 ml. It's a teaspoon of fluid. It's about 5 milliliters of fluid. It's a very, very small amount of fluid, but it has to be put in. It has to be next to the bowel. A suppository has to be next to the bowel wall. If it is put in the middle of stool, it won't trigger the peristalsis in the bowel, those little fibers that are moving the stool along, and cause that contraction in the intestines to move that stool along. If it gets put in the middle of stool, it doesn't have the body heat to melt the suppository. It doesn't have the connection with the bowel. It's not going to work. So if you find that there's a bunch of stool there, you might have to remove that stool and then put the suppository or the mini enema in to make it work. So all that is in all of the bowel programs. And then when you feel like you'll get to know when the stool is ready for expulsion, and that's when you want to transfer onto the toilet or onto the commode, because that lets it just drop out. It makes it, when you're doing it in bed, you're trying to push it out sideways. When you're doing it on the toilet, it's gonna fall out through your bowel. So it works much quicker, easier, faster. Here's a question about multiple sclerosis. Multiple sclerosis is a spinal cord injury from disease, and people often who have spinal cord injury from disease don't often think about being a spinal cord injury because they identify with the disease, which is perfectly normal. But the philosophies and the treatments are the same. So they say it's a white matter disease of the brain. And And what about having it in the lumbar or neck? Can you still get an MS diagnosis? Well, white matter is in the brain and the spinal cord. It's all in the central nervous system, as is the gray matter. And we now know that MS it has one effect on white matter, but also has an effect on gray matter. And what MS is there's myelin, or like an insulation. It's a coating of fat, gooey stuff that goes around each nerve bundle, and that keeps the message going down the nerve. It keeps those messages traveling through. That is what happens with that in MS. That myelin, for the immune system attacks the myelin for some reason. They don't know why. And when that myelin dissolves, that electrical message can't travel the range of that nerve, so it tends to trail off, and that's what happens. So in MS, there's problems that can occur in the brain, but there's also a lot of problems that happen in the spine, and that's where the problems, mostly with the walking and the bowel and bladder, it's usually because of plaques. They call them plaques in the spine from the MS. And so yes, you can have MS in the brain and the spinal cord. Some people have more in the spinal cord, some people have more in the brain. It all depends, and it depends on what nerves are affected, what parts of your body are affected, but it's that plaque that happens. But they're working a lot in trying to help regenerate that plaque, and there's medications that are helping slow the progression of the MS disease. So important to talk to your doctor about those things. Typical standard treatment for body spasms, and this person's been on different medications. So body spasms are tone in a C4 or 5 quad can be go throughout the whole body. So if you've tried different medications and they've tried oral medications, the baclofen and different medications. So if that's not working, sometimes the baclofen, the body gets adjusted to those medications. So sometimes if you're on the baclofen and it's not working, you have to up it and keep upping it at different periods of time. Now, if you have tone like that's just in the legs, most people are deferring to Botox injections, or just in the arms or in the neck or wherever. Most people are referring, not in the neck so much with the Botox injections, but if it's in an isolated place like the legs, people will go with the Botox injections because that works just in the legs. Whereas if you take oral medications, it travels throughout the body, and you kind of get foggy and you get real tired until your body gets used to it. And then by the time your body gets used to it, it's time to go up on it. So then you start that cycle all over again. So if the oral medications are not working and this whole body spasms, you might want to consider a baclofen pump, which allows for a lot more medication to go into the body, but it doesn't travel up to the brain. So it's an implant that's put into the body. There's a little device that goes in the abdomen, and then there's a tube that threads around and they place the tube into the spinal canal, which bathes the whole spinal cord with baclofen that resolves the spasticity. And so most people with these really horrendous body spasms will opt for that baclofen pump. Now, it used to be you had to have a trial and then they'd see if insurance would pay for it, but most insurance companies have eliminated the trial. If you have the situation, the pump works so well, they're just like, okay, put the pump in. And so that would be something to investigate for that. So that would be like the next step up above that. Okay, here's a person who has a C6 AGD spine contusion. This is year 3. They're trying to deal with their new reality and all the nerve damage and constant falls. Yes, and that's something else that I wrote about this December, because with the holidays and the change in the year and cold weather and not being able to get out, people tend to get a little bit depressed. You know, it's harder to do things in the winter time, and it's cold and your body cramps up. It's harder for everybody. If you have a spinal cord injury or not, the days are shorter, it gets darker earlier. It's just kind of a tough time of year. You know, and we think a lot about grief. And if you've lost somebody, it can produce a lot of grief, and you have grief for the rest of your life in that situation, and that's the way it is. But you have to learn how to manage your time, manage your way through it. I don't think you ever get over the loss of a loved one, but you manage your way through it somehow, and you learn to adapt that this is the way that it is. And but what people don't think about is that grief also comes with a loss of function or a change. You could have grief over a loss of a job, or any kind of change in your usual routine or life. If you suddenly are faced with a disability, there's a lot of time for that, and it takes a lot of time. And really, you need, depending on how severe it is, and after 3 years still trying to deal with new reality, it's probably time to talk to a professional who maybe can help you work through some of those issues. Now, they can't make it right, they can't take it away, but they can give you the tools, to know like what your triggers are. For me, I have developed a new trigger for grief in death of a loved one, because just this year, because there's so many commercials on TV with honoring people who are no longer with us over the holidays, and some of them are very nice, some of them I really like. There's this one thing that I myself personally, it is my issue that I can't take, is when somebody gets on TV and says, well, there's one less place at the table, and that just sends me off into a grief spasm. But especially when they do it with that real quivery voice, it's just like, seriously. Now, there's some commercials on TV that I have seen, and they have done it so well that it warms my heart. So I know that this is my issue, but if you can figure out what your triggers are to help you get through that grief of your loss, then help you deal through that's a real gift to help to learn to do that. It worries me that you're having constant falls, and that's just a reminder of the issues. So if you can do something to avoid your falls, if you have some adaptive equipment, use it. With an ASIA-D, you can get stronger and help overcome some of those constant falls, and slowing down too helps. So, we're talking about the wheelchair, and we're going to push that wheelchair, and we're going to get moving fast. People like to move fast. Take your time, stand up, take a moment just to get your balance. And as you get doing that, it becomes second nature, and it doesn't take so much time. It just becomes second nature, because now you don't have to pick yourself up from falling again. So you're really saving time by just taking a second and adjusting to being standing. And then, if you use a cane, or if you use a walker, a wheelchair, whatever you can use to help keep yourself from falling. Some people will use foot splints so that their ankles remain stronger, or, use some splinting around their knees to help kind of balance themselves a little bit more. So all of those things are very important in taking care of yourself. And I think that if you can deal with the constant falls and eliminate some of them, not only for the safety of your own body and your own life, I think that, that will help with some of the adjustment to injury when you kind of get it figured out together. So talk to your healthcare professional. If you've gone through rehab, it's been 3 years ago. There's a lot of new things out there. There might be some devices that might strengthen you that they didn't have before. So talk to them. In most people's insurance, if they have private policies or if they have a Medicaid policy, there's 2 weeks of mobility training usually built into almost every policy. So you can use that. You don't have to go Monday through Friday for 2 weeks. You can go 1 day a week for 10 weeks. So there are all kinds of things, and then learn as much as you can in therapy. And then you can continue to do those exercises when you're at home. What are your thoughts about hand washing? In particular, those people who have those long fingernails. So these people went shopping, and this lady had these really long fingernails, and they got the flu shortly after. Well, could have been that lady, could have been, but probably not her because the flu is airborne. So it's probably somebody in the store. You know, you can get the flu sitting in your house all by yourself because that virus makes its way into your house. And, you know, you breathe it in and that's how you get that. So yes, those long fingernails, unfortunately, we can't control other people's hygiene and or grooming or what they find fashionable. So that is unfortunate, but yes, if you don't like that, they said they're going to go to a different checkout clerk next time. And that is your right, as it is their right to have their long fingertips. But yes, nurses wear their fingers short. There was a problem in one of the neonatals ICU where the babies were getting these infections. This has been many years ago. And so they did all kinds of testing. They tested the bed rails, they tested the walls, they tested the floors, they tested all the equipment. They couldn't find the source of infection. So then they went around and they started testing people. They tested their eyes, their nose, their ears, everyone who went into their mouth, they tested. And you know where they found the infection was underneath artificial fingernails. So now when you go to the hospital in the intensive care unit, adult, neonatal, pediatric, those artificial nails are not allowed. And so many nurses like me, we just don't do that sort of thing because we know that's where the infection is. So yes, you're right, but there's not a lot we can do about that in the public. Okay, so here's somebody learning how to cope. They're a hospice nurse. These things are not to happen to me. I think everybody who has a spinal cord injury or somebody in their family who has a spinal cord injury feels that exact same way. So know that you're not alone. But please talk to a group, get in a support group. There are support groups that you can join online, or you can go to support groups for people who have different kinds of disabilities. There's the peer mentoring group. If you want to talk to somebody through the Christopher and Dana Reeve Paralysis Foundation, they're a wonderful group of people. There might even be somebody available in your own community. You can talk online or you can talk on the phone. You know, we forget about that these days. Or you can go to, you might be able to find a group of people. You can talk to a healthcare professional. It does not mean there's something wrong with you. There may not be anything wrong with you. It just means that you're checking in with your mental well-being. You want to keep yourself mentally healthy because that keeps you healthy in your body. So thinking about those kinds of things, just go, maybe a chat one time, but they have a lot of coping skills that can really help. And somebody else is seeking assistance on how to get a wheelchair evaluation. It's very cumbersome trying to get that done. Yes, it is difficult. Sometimes people see things that somebody else has. Maybe your insurance payer is not going to pay for that. Maybe they got that private pay. Maybe they paid for it themselves, but talk to your healthcare professional. If they find you need some different equipment, you can get that evaluation. You usually need a physician's order to have that done. So chat with them about that. And we all know that equipment doesn't last as long. Perspective that this equipment will last this long. Equipment takes a lot of use and it gets a lot of abuse when a body's being transferred in and out of that. It's not like somebody lightly sitting on a chair, although most of us flop down anyway, but it's not like, it's when you transfer and you're moving and you're pulling on that chair to pull yourself, it takes a lot of wear and tear on equipment. Seating equipment can lose its cushioning, and so it can be a challenge. But keep at it and see what kinds of things you can do to try to help yourself along in that regard. There's some other things that have been written in the Q&A, and somebody saw an ad for Eucora, and that's another one of these bladder products. I've only known a couple of people who have taken it. They seem to like it. I don't know anybody who's taken it and said, oh no, this wasn't for me. But as I say, I've only known like 2 people who've used it. So again, talk to your healthcare professionals so they can look up and see what the ingredients are. and know what it is. Somebody else said that they've tried Utivia and they didn't think it helped. They thought the same, that the D-mannose didn't help, but maybe they didn't try for it long enough. You know, it's really a trial and error, but you have to be very careful with what you take, because a lot of these products have things in there that maybe conflict with your usual medication, or they have a lot of sugar in them. So be careful about that. A C5-6 injury, what can I do to reduce hemorrhoids and erectile prolapse from 15 years of Magic Bullet? Does that make it worse? Is bleeding common, and what can I stop to or avoid it? Well, if the hemorrhoids are small enough and they're protruding from the rectum, you want to be able to push those. You want to be able to take some hemorrhoid cream or some lubrication, moisten them and keep them back, put them back up into the rectum. Now, why do that? Because that's a warm, moist environment, and hemorrhoids are vessels that are overfilled with blood, and when they get out of the rectum, they're in a dry area, so they tend to bleed more often. So if you can put those back in, that's one way. Trying some Preparation H to help shrink them. Again, check with your healthcare professional. Now, the one thing you do not want to do is have them surgically cut or excised to remove them. If your doctor recommends and your surgeon recommends removal, you want that where they put rubber band them so that the vessels close off slowly. The hemorrhoids just drop off if they're external. Those are very, very severe processes. So most people we try to treat, and most people are successful using the reinsertion and the Preparation H, maybe some Tux, if that's helpful. Be sure you use a lot of lubricant when you are doing the bowel program. Again, it's that rough glove against the internal bowel tissue that helps create those. 15 years of bowel program and the Magic Bullet suppository, did that make it worse? Well, if you did the bowel program with a well lubricated finger, and if you didn't sit on that open area of the commode, you know, where your bowel has that opportunity to do hemorrhoids or prolapsing, those are kind of more, it's not the bowel program, it's kind of more the other pieces of the puzzle. Here it's an hour, so it's time for me to say goodbye. Happy New Year. Oh, there was one more question I'm going to answer it real quick. Do you know when you should consider a colostomy? That is when you decide that you would like to do that. This is what I tell people all the time. There are people who have colostomies. They work wonderfully well and they love them. There are an equal number of people who do a colostomy and they have nothing but trouble with it and would love to go back. And sometimes they do have their colon reconnected to go back to the bowel program. There's a lot of trouble that people have with keeping the bag on. The bag falls off, the bag explodes, you know, all these kinds of things. So again, most people have it because they think it'll be more convenient than the bowel program. It's usually not. But again, it's a matter of some people have it and they just think it's just grand. Other people have it and they don't. Some people have it. I've known not a lot, maybe like, maybe 6 or 7 people who've had a colostomy and have died from the colostomy. It is not something to take lightly. And I say that not to scare anybody, but it's just not something to take lightly. One gentleman I know that had an unfortunate outcome did it because he just didn't want his wife doing that anymore. He couldn't do it himself. He was a higher level and he couldn't do it himself. And he just didn't want his wife doing it anymore. She was a nurse. She's like, Linda, I don't mind doing it. But he was adamant about it. He pursued it. And unfortunately, he had a very bad outcome. And I in his honor, I'd like to think twice, because he was having a pretty great life. And so that makes me sad. But I don't want to end on a sad note. Happy holidays to all. Happy New Year. We're going to end into a new year. I'm expecting one great thing after another. All right. So off we go. Have a good time. See you next month. Oh, one more thing. On January 11th at 2 p.m., we're having a program with Dr. Robert Fuller about paraplegia or spinal cord injury and pregnancy, not paraplegia, but pregnancy. So that'll be an interesting seminar. So I hope to see you then. Bye.